The topic of challenging behaviors with epilepsy, especially with Dravet and other encephalopathies, is a very general one, and in the 20 minutes I'm not going to be able to talk about everything in detail, so I'll be very happy to take lots of questions from people here and online as well. It's a great privilege and honor for me to be here, and I enjoy the work that I do. So as Ingrid was saying, we run a dual disability service for kids with 90% of them have various forms of epilepsy, but predominantly with autism and intellectual disability with very challenging behaviors. And we are in the process of expanding that clinic, potentially looking for funding to do some outreach in-home consultations. So that's another thing that we will be doing. So what I will do is to just do an overview of the various aspects of things that we see in our clinics and in the histories presented to us by families. With the challenging behaviors, they affect a whole range of different things, but the three main areas that you could sort of encapsulate them into are cognitions, learning, memory, attention, concentration, impulse control, all those things. Emotions, which could be a depressed mood, an anxious mood, or a manic kind of mood, sort of stuff, and behaviors, which could be aggression, self-harm, self-injurious or self-pitying behavior, head-butting, and all those things. So different types of behaviors that come in that. All these behaviors are, must say, common in a lot of the different kinds of epilepsies, but they're much more pronounced if you have a genetic pathology and a brain pathology rather than an epileptic phenomena or a neurological problem where the problem comes and goes. If it's an embedded problem, then the behaviors are much harder to manage. And with regards to the various different kinds of problems, if I could start with the cognitive type problems, inattention, hyperactivity, and impulsiveness, they affect learning, they affect the memory, they affect behaviors, they affect the ability of the children to socialize, and it increases the risk of injuries and accidents. And in some children is non-responsive to the usual treatments that we would use, and I'll talk about that in a minute. So that's the first point I wish to make, and I'm happy to take questions and elaborate on them. Aggression and agitation, I've just sort of described them in general, and that can manifest in lots of different ways. The aggression can be in the form of self-injurious behavior, picking, biting oneself, head-butting, but it can also be aggression directed at other people. But apart from that is agitation. So agitation is a mood and behavior-related phenomena, and it could be driven by anxiety, it could be driven by distress, it could be driven by an inability to comprehend what's going on around. It could be made worse by the environment in terms of if there is too much stimuli or too little stimuli, which is another thing that we often find, that when these children are removed and placed in an extremely quiet environment, they actually can sometimes get worse. They need that fine balance between too much stimuli, not good, too little stimuli, not good, but just the right balance in between. And that's something which has to be worked out on an individual basis, and using observational methods and talking to people and gathering data and all of that. Sometimes it can be due to, never forget that these children live in families, and families can experience trauma, they can experience deprivation, there is a lot of stress sometimes happening in families. So what affects the other members of the families can also affect these children, and that can also affect their behaviors and their emotions and their feelings as well. The frequency of the seizures can also cause some of these problems, in that we find that it's an interesting phenomenon again, and it varies from child to child. And then some children, the increase in seizures actually dampens down the behaviors. And that has been noticed for a number of years, and that is one of the reasons why in psychiatry, at least in adults, they started to use electroconvulsive therapy as a means of helping lift people's moods and decreasing aggression and agitation. So that was the sort of thinking behind that abnormal electrical activity in the brain can cause either a decrease in agitation and aggression, and in some older teenagers and young adults where they have psychotic symptoms, delusions and hallucinations, the seizures actually act as a dampening effect or a treatment effect. And whereas when you treat the seizures, those behaviors get worse in some kids. And the reverse can happen, where the behaviors can be bad along with the increase in the frequency of the seizures as well. So again, that is very variable, and I don't think we completely understand the mechanism behind that. And that research is still underway for that. Sometimes these children can be in situations where developmentally they may manifest with autistic traits. And there's been some work done in trying to understand why that happens. And we now believe that there's this triad of epilepsy, intellectual disability, and the combination of that with some abnormal social and emotional development that we now diagnose as autism. We must remember that in terms of the diagnosis of autism, the landscape has changed. When I started in child psychiatry, it was a very restrictive diagnosis given only to a small number of children with a very unique set of problems. And there was an entity called classical autism. There was another entity called Asperger's syndrome. But now they've done away with all of that. In the new classification, which came out in 2013, the DSM-5, we now have the autism spectrum disorder, and it's now considered to be, people are considered to be on a spectrum. And I think there is a move eventually to even make something like ADHD a spectrum disorder. So we believe that social development, attention and concentration, and impulse control is actually on a spectrum, with people being at different levels. Some extremely good and some really bad, and lots of people in between. So this is across the spread of the entire population, even us neurotypical normal people. Our skills and abilities to manage impulses, pay attention and concentration to task varies enormously across the day, and also depending on the time of the day and all of that. We know that. So it's like a kind of a rhythm, almost a biological rhythm. So now increasingly people are recognizing these categorical diagnoses in psychiatry don't work. So they're actually coming up with dimensions. So that may be where we would be going in 5 years, 6 years' time. Sleep can be a huge problem, and there can be difficulties with falling asleep, with frequent waking, and that can be associated with, again, poor attention and concentration and poor behavior. But there are a subset of children for whom treating the sleep actually worsens the behavior. So if they have too good sleep, then that can be a problem. They just need to have good enough sleep, it seems. Like they actually manage better with less sleep. Whereas there are a large number of children who go the other way. And we find that in practice, so they come in to say, there's poor sleep. So we go, okay, let's sort of support the family and let's sort of support the child. And we might prescribe medication. Sometimes it might be something mild, like melatonin. There's this agent called Zopiclone, which is often used in the older children, teenagers. It's a pure sleep-inducing agent. It's not a Valium-type drug. It's not addictive in that sense. It's a pure sleep-inducing agent, relatively safe with some of the anti-epileptic medications that would be used. It allows kids to sleep for 6 to 8 hours, and then it leaves the system. It doesn't make people feel drowsy the next day. Sounds wonderful, sounds fantastic, sounds like the exact kind of thing that all of us need. But then what happens is that sometimes these kids' behaviors get worse when we give them that really deep, good sleep. So that's something that we have to kind of balance out. Just in terms of treatments that we would use, and jumping quickly to that, I'll talk about medications first and then some behavioral management. Inattention, hyperactivity, and impulsiveness, we would use medications like Ritalin, the short-acting Ritalin, the longer-acting Ritalin to maintain that over a period of time. It also comes in this trade name of Concerta, and there is lisdexamfetamine, which has been around for a few years now, that people say is a more sophisticated molecule with fewer side effects, and the effects last longer throughout the day. and there's better learning and things like that. The studies are still underway in the Australian population as to whether head-to-head comparison, whether Lisdex is better than Ritalin and the long-acting Ritalin, but lots of people from the UK and the US swear by Lisdex as being a good one, and that's the long-acting version of dexamphetamine. We are being told that we will have a couple of other medications available in the market in the next couple of years. There'll be long-acting clonidine and long-acting guanfacine. These are two medications that are sometimes used already in the short-acting versions for exactly these problems. So we might have a few more medications in a few years to manage this. In terms of agitation, aggression, and self-harming, it seems that the mechanism could be a combination of poor functioning of the frontal part of the brain, which is impulse control, judgment, reasoning, understanding, anxiety, and in those children who are non-verbal or whose verbal ability is limited, frustration that comes out of not being able to communicate. And apart from all this, a lot of these children can suffer from chronic depression, which is not easily identifiable because a lot of the textbook description of depression in psychiatric textbooks pertain to people who can voice their complaints and describe them in detail, and it's impossible to get that kind of assessment from children. So therefore, we often go based on symptoms like irritability, oppositional behavior, poor sleep, poor eating, a decrease in performance in school that is not explained by other reasons, and we would suspect depression. So for a very large number of these children, we might use medications like this. Some people have wondered about whether we should be using more antidepressant medications. They could be used in the older teenage population with some caution because sometimes they can activate children and actually make them more agitated. So that's something that we have to keep in mind. Now, these medications are not without their problems. They cause weight gain. They can cause sometimes the opposite effect, an increase in aggression and agitation. And so it has to be tailored to the individual child. Behaviorally, the thing about behavior therapy is that behavioral therapy philosophy is based on the principle that all behaviors always occur due to a reason. There is nothing that occurs spontaneously. There's nothing that ever occurs just out of the blue. It always has a reason. It always has a cause. You just have to find what the cause is. It always is preceded by some early warning signs. We just have to get better at identifying what they are. It's always possible to describe the behavior if you get better and better and better at tuning into that. And it's always better to find out what happens and then create a plan to manage that. So that's what behavioral therapists would do. And that's why we have some group education programs for parents who are dealing with children with behavioral problems and things that are available, and I can give some information about that afterwards. But it starts off with identifying what the triggers are. And how does it start? Who was involved? Was there too much stimulation in the room or too little stimulation in the room? And was it set off by the parent sort of setting limits or imposing a demand on the child? It's stuff like that. So a really good, thorough understanding of what might set it off is really helpful. It doesn't require an expert behavioral psychologist to do this analysis. In fact, parents can be really good at doing that because you know your children really well and you can tell when those behaviors are coming on, and you can actually start watching the patterns of how those behaviors emerge. It's just about tuning into the triggers or tuning into what's going on there, and it's possible to identify that. But a description of that can be really helpful for a psychiatrist or a psychologist to then come up with strategies. The next stage would be B, which is behaviors. Describe them, describe what is actually happening. So always try to imagine that you're talking to someone over the phone who's not witnessing that in person. How would you describe an event that has happened to you or that you witnessed around you to someone over the phone? You would sort of give them as much detail as possible. You would pause and think about what else you have forgotten to include, that sort of stuff. So try and do that. Write notes of behaviors that you observe, especially the ones that occur frequently. Look for patterns in your own notes. And this can be really difficult and challenging because, you're kind of focusing on what's wrong with the child at the time. And this can be really stressful. So my suggestion would be to probably just observe and watch. And for some people, it's easier to make small notes along the way. For a lot of other people, it's easier to write notes on their phone or in a notebook at the end of the day when it all has finished and you've had some time to wind down with a cup of tea or something and just make some notes. That sort of stuff is really, really valuable. It's like a textbook on the child. And it's so valuable for a behavioral psychologist or a psychiatrist. Don't underestimate your role in that. You are the experts, and there's so much information you can give us that will be really, really helpful. The last bit is the understanding the consequences of what happens with the behaviors. And how does it end? Who makes it stop? Have you done something to make it go away? Has a child done something to make it go away? Has someone else done something to make it go away? Does the child tire themselves out? Or do they get what they want from you? Or how does that stop? Or did a seizure come on and actually make the behavior stop? So all these things, again, very, very, very helpful. So just going back quickly over it, watching the good is also really important. Watching good behaviors, looking for opportunity to praise, making note of that, monitor anything positive that's developing as well, and also make note of what is being done well, make note of little things that the child is learning from their own behaviors. Watching the bad and making note of that is really important. But as I said, that sometimes you might have to take it in turns with a partner or some other family member to say, can you do this for a couple of days? Because I don't want to be focusing on that all the time. I'd like to, tune in and have a good time with the child and not just make notes of what's going on. So that's something to keep in mind. And sometimes you have to monitor the really ugly stuff, the real violence and the real wild behavior, the smearing of feces in the toilet, or the head-butting or the biting or the attacks, random attacks at people walking around or something like that some impulsive, aggressive children can do. It is possible, I must say, to do a really good home-based behavioral plan. And it's easy to do, it's possible to do, and a lot of it is writing down stuff that you observe and then taking it to a psychologist and having them describe that for you. So some of the things, having trouble seeing the slides. Make a list of things, and that's actually always quite important. The most important thing is to make a list of the behaviors that are challenging and create a hierarchy always, starting at the top from the easiest, the most easily changeable behavior to the one that's hardest. Because just like the child, each item that you tick off as you go down that list from the easiest to the hardest, the more confidence you gain, the more energy you gain, and the more you learn about how to deal with it. So as it gets to the harder bits, you've actually acquired some knowledge yourself, and you've had an opportunity to discuss that with a psychologist or a friend or someone in dealing with that. So that's kind of really important. So making a hierarchy and starting with the easiest to deal with behavior and then going to the worst one. And then in doing that, be realistic about what you want to achieve. Of course, you want to stop the dangerous behavior, the extreme impulsiveness, the self-harm, that sort of stuff. But there may be some things that you say, I'm just going to ignore that for now. I'm not going to fight that battle because I'm going to choose my battles and focus on what's most significant for me and make sure that there is an opportunity to also reflect on what's good in there as well. Some really simple interventions can be helpful. We call something called emotion coaching. And emotion coaching really is and psychologists can do this with parents, but you can also learn that from reading some books. And I've got in one of the slides here in the end a book that you can download free from the internet and read. It teaches the basics of emotion coaching to parents. And it's all about tuning into the child as best as you can and looking for subtle changes in the emotions. It's easy to be, affected quite expectedly by all of the big behavioral changes that occur, but the small little changes that can happen in the emotion and feeling state are important to keep in mind and make a note of as well. So that's emotion that you learn to become a person who reads the emotion of your child and change that. Working on routines and having reminders, giving pre-warnings before something happens, and using social stories, and now you have a lot of stuff on the media that you can use. You can actually download things from the internet that help create visual social stories that use cartoons. So it's actually much more visual than the traditional paper and pencil version. And we found them really work really well with a teenager that we used on recently. She really kind of warmed up to it. It had cartoons from different cartoon characters, and we were able to create a social story out of that. It's possible to do that. I don't think it costs that much. There is a small fee involved. And having some practical calming strategies, like some sensory sort of tools and strategies, would be really helpful to... How are we doing for time?
I was just looking, you have a little bit extra. I didn't realise that. So you've got another 2 minutes.
Another 2 minutes?
Yeah. Probably another 5, actually, because we started pretty late.
Thank you. Okay. Okay, I might jump to talk about... Okay. Visual reminders, really, really, really helpful. They say that you can create an environment around a child where they have a lot of guidance, and this comes after this, and this comes after that, this comes after that. For some children that works really well, because that structure, the visual with the visual aids, can be really helpful in guiding them from one thing to the other, and they feel contained because they don't then have to imagine what's going to happen next for me. I've finished this task, what's going to happen after that? For some children, they can go from task to task, only thinking about it one thing at a time. For other children, they start to imagine things, when they wake up in the morning, how is my day going to be? What am I going to do? When am I going to get to school? And then what's going to happen after that? And then what's going to happen after that? So having a visual schedule around the child is really helpful. That website, there are a lot of visual schedules that you can download, and there's another one in another slide as well, where you can download for free schedules that you can create of your own for various different activities. So that's kind of really, really helpful. And writing a checklist and ticking it off. And the checklists do not have to be in lots of words. It can be in pictures. And as you finish tasks, you can actually take them off that list and put them in a box. It can be like that. Giving lots of pre-warning, which is using these schedules to sort of inform the child about what's going to happen and how you're going to deal with that is really, really helpful. And there are different kinds of timers and alarms, and using sand clocks and timers like that can be really helpful. So you can kind of say that by the time the sand runs out, I want you to go to the toilet and come back, or I want you to finish that task, or something like that. And then you might have to actually do it with the child to sort of show them how it's done. So that's kind of how they do the coaching part of it. This is really important. Giving instructions. It's quite interesting how we kind of find that when we talk to parents and we sit down and we the parent says he never listens to me, he does exactly the opposite of what I ask him to do. And we then sit down with the parent and say, can you describe how you give the instruction? There was one mother who described to me how she did it. She was cooking in the kitchen. The child said, can I do that? She said, no, you can't do that. 5 minutes later, and then she kept cooking. And he didn't get it. He just went and did it anyway, because he couldn't see his mother in front of him. He couldn't symbolize her voice and hold it in his consciousness and follow that, because he hasn't internalized his mother developmentally. And that can be a problem for these children. So what we advise parents to do would be to stop what you're doing, come and sit, simple stuff. So come and sit in front of the child, make eye contact, be really clear, give very simple instructions. Don't give more than one instruction at a time. Don't give conflicting instructions. That sort of stuff can sometimes be helpful. And you may already be doing it and you may find that it's not working. We can talk about that at the question and answer sort of session. But even this sort of stuff can be really helpful. There are lots of sensory stuff out there, and it's getting more and more and more and more sophisticated. And there are lots of websites that you can order things from, but the national OT website for autism has got a lot of this. The child does not have to have autism to be able to order some of these things. Of course, to get funding, it's tied to autism. I understand that. And the definition has broadened out, and you find that lots of children meet the criteria. But a lot of the sensory stuff is really helpful. And creating a sensory diet and having a sensory box is really, really, really helpful. The other important thing that I would suggest is getting on the same page as the school and trying to see what they're doing and how we can achieve consistency between home and school and how we manage things. I'll finish with just projecting some of these resources that I've collected, some useful websites where you can download tip sheets and fact sheets, some where you can order sensory tools or visual schedules and things like that. That's a useful book to read, No Drama Discipline. You'll have copies of these slides. What I will do is I will take some questions, and I might actually add the answers to those questions to the slides and send them out so that you have more information in them. Thank you.
Thank you very much.
Thank you very much. I think it's an incredibly important area. First question over here.
I just wanted to know about diet and if diet plays a part in behaviour, or you feel it does.
There's been quite a lot of study about food colouring agents and amount of sugar and carbohydrate with aggression and things. And what we find is that, yes, there is an impact if children are consuming large amounts of caffeine-rich liquids and lots of carbohydrates which burn off energy really quickly or let off energy really quickly, and if they are consuming a lot of liquids with colouring agents in them, yes, that actually increases restlessness, increases hyperactivity. Yes, not so much impulsiveness, but restlessness and hyperactivity.
Okay,
definitely.
thank you.
Okay, hands up if you have another question. And whilst we go over here to Wayne, I'm just going to ask you, Pam from Australia asks, is risperidone okay long-term in adults?
Yes and no. Yes, in the sense that with careful monitoring, yes, it's possible to use risperidone in the long term. The thing that I find is that sometimes people get put on a medication and there's not a review of that at some point in terms of do they actually need this? Do they need this at this current dose? Is it possible to reduce doses? We've seen some children and teenagers in our clinic where we've been able to halve the dose of the medications simply by changing the way we use them, by dosing them differently. We've managed to reduce the total daily dose by half. So as long as we keep continually working on that, yes, it is possible to use it long term.
So this is risperidone you're
just in risperidone itself, and we've been able to reduce weight gain and actually improve the behaviours without using as much, just by varying the dose.
Yeah, we've got a lovely young girl who has Lennox-Gastaut syndrome, so she doesn't have the negative behaviours. Has a very nice personality, but I'm concerned around depression. We spend a lot of time during the day talking about negative things and people that have died. And I'm starting to think that how do we actually, because of her ability to speak, you can't have an intellectual conversation with her. How do we sort of look at, or how do we sort of try and manage whether it is depression or where should we head to try and work out how to better improve her lifestyle?
Yes, of course. That's a very valid question. It's a really important question. And it's possible through cognitive behavior therapy, for example, to give her skills so that even if she is, not currently depressed, that she's able to cope with challenges of life without becoming depressed. There's a modified version of cognitive behavior therapy that many psychologists use in Melbourne. So I'd be very happy to give you some names and contact details of psychologists who can do modified CBT with children like her, young people like her.
Thank you.
Can I ask you for a quick answer? Helen from Australia asks about the most effective medications for severe psychiatric disorders and behaviours associated with PCDH19 encephalopathy.
There is not a one medication that will deal with it all. We would tailor the medication based on what the symptoms are. And again, the thing that I find increasingly is that a really good understanding of what the behaviors are and what we're trying to achieve in treating those behaviors will help us choose the right medication. And there are, even in the same family of psychotropic medications, differences between one and the other in terms of what it's more effective for. Like, for example, Abilify is slightly more effective for mood fluctuations and repetitive self-harm than risperidone is, and all of that sort of stuff. So it's something that we can choose carefully. There's not the one medication, but it is possible to tailor the treatment, definitely.
And another quick answer, please. How often are behaviours caused by seizure activity? Are there any good psychologists for kids like ours who may have behavioural issues that seem not to be explained by anything logical? Thank you, Pam. Or Carolyn. Thank you, Carolyn.
Yes, behaviours can be affected by seizure activity. For some, behaviours decrease with increased seizures, and the opposite can happen as well. I have seen in my clinic probably a 50-50 split between the two groups. With the 50% kids that I see, in fact, the behaviours improve. And so we then have to talk to the neurologists about changing the dosing and just kind of letting some seizures happen safely so that the behaviour is under control. And there's a significant improvement, then the child manages better at school. And then there are the others where you have to treat the seizures in order to help improve the behaviours. There are some psychologists who do see children with epilepsy, with severe behaviours. They are generally overbooked, but it is possible to get into them. We are putting together a list of the psychologists. We're actually creating a database, and we should be making much more progress on that by the end of this year, so we'll be very, very happy to share that around.
And the last question, I thought was one that we really needed your help with, from Susie from Australia. What about odd behaviours that are done for pleasure, such as pulling out eyelashes and eyebrows? Apart from distraction when I can, what else can I do?
There is a specific behavioural intervention called habit reversal. So behaviourally we see them as habits. So the habits are sometimes done just for routine or out of routine. Sometimes they're done for pleasure and to reinforce that pleasure sensation or feeling. And sometimes they're used as subtle ways of managing an impending anxiety. So even before the anxiety comes, the child manages that by doing this sort of repetitive behavior. There are behavioral interventions that you can use where there is it's clearly associated with repetitiveness for the sake of habit or obsession or anxiety. We can use medications as well. The SSRI medications can also be used for them.
Please join me in thanking the
Thank you.